Thank you, Dr. Price Kerfoot, for joining us today to talk about your work in digital medical and surgical education. Can you go ahead and tell us a little bit about yourself and how you gained an interest in this work?
Happy to, and thank you very much for the opportunity to join you. I finished my surgical training here in Boston at the Brigham in 2002 and did what many folks said would be shooting my surgical career in the foot, which was by focusing my research on education, in particular educational technology. The primary focus was to use clinical trial rigor to evaluate what are bells and whistles and what actually can work. And so in the last, I'd say about 8 years, we've done over 20 large randomized trials that have investigated different aspects of different methodology to kind of determine this. Initially, my first large randomized trial was conducted in 2004 with 350 medical students at 4 medical schools, seeing if web-based teaching modules, the gold standard at the time, the click-through question-answer clinical scenario format, that these, in addition to a surgical rotation, could increase or not students' learning from their rotation. And we found that those randomized to the modules did actually learn significantly more than those who were not. And we did something that was unusual at the time, which was we tested longer-term retention 5 months later, and we were thrilled to see that the folks that had received the web-based teaching actually had greater retention of 5 months later. We were thrilled. It was published in Academic Medicine. I mean, everything's great, right? Well, not so fast. If you carry out the curves from when they initially received the web-based teaching and carry them out to 5 months and about to a year, those two curves, the forgetting curves, are merging and going back down to baseline, from which they would merge at about a year after the intervention. So the question that faced us is, why are we actually wasting a week of these students' time, which correlates to about $1,000 of their tuition, to teach them something that they don't retain? Or on a more positive spin, how actually can we change the learning process itself to improve the acquisition and retention of knowledge? So that led to a deep dive into the cognitive research literature. And there were 2 main psychology research findings that we utilized to develop a new form of online education, which we termed spaced education. The first of these is the spacing effect, which was initially elucidated by Ebbinghaus in the late 19th century. And it refers to the finding that if you present information in bite-sized chunks and then reinforce them over spaced intervals of time, it can increase the efficiency of uptake of the knowledge and encode it in such a way that it's preferentially retained. And there appears to be a distinct neurophysiologic basis for this effect. So they've been able to show it in fruit flies. They've been able to show it in rats in terms of being able to escape from a maze more quickly, those who receive the spaced learning as compared to the bolus learning, or as we call it, binge and purge learning. The other was for the in those rats, they were able to then look at the hippocampus, and there were increased neuronal longevity and number in the hippocampus, which is the center of longer-term learning. In Drosophila, they were actually able to identify the phosphatase mediator of the spacing effect. Wow. And now fMRI studies are being conducted to try to elucidate where in the human brain this effect is centered and how it actually can be optimized. The second finding from cognitive research that we utilized was called the testing effect, or in the literature is termed retrieval practice. And there have been quite a few studies in the last couple of years in science based on this. And a lot of this work has come out from Roediger and Karpik at Washington University. Most people think of a test is that you put a dipstick into the tank, pull it out, and say how much knowledge is there. But actually, the process of being tested or retrieving the information can dramatically improve long-term retention of knowledge. And they've done a whole range of different randomized trials looking at this. And it can be incredibly powerful and is transferable to many populations. And as there was actually a study that was done by Moulton et al. Up in Toronto with surgical residents. In this case, here it was less testing. This is more on the spacing effect. But what they looked at, this was a wonderful application of this, is that they took, as you know, our surgical training centers are usually you show up at a conference center and then you spend the whole day dissecting pigs and you go home and you're expected to develop these skills and retain it. But ultimately what they did is they took the residents and either had them do 4 hours of training at a single weekend, or did an hour of training over 4 weeks, and then were able to test how quickly they attain the knowledge, and then those who had it spaced over time actually had greater acquisition and retention of the knowledge, and also greater transfer of those skills to a microvascular suturing model. Wow. So that was beautifully done. Wow. So this was back in 2006. Harvard nicely jerry-rigged a system on their learning management system for me to send out emails in a question format to take advantage of the spacing effect. People would submit their answers, and then we would give them feedback, and then we would reinforce it over spaced intervals, again, trying to combine both the spacing effect and testing effect. And recently, we've been able to incorporate some powerful game mechanics in that, actually, to really boost engagement. Mm-hmm. So we've done all these randomized trials. Harvard submitted a patent on the methodology and then launched a startup company called QStream based on that, of which, conflict of interest, I am on the board and have some equity. And so it's been for a prostate surgeon here at the VA in Boston, it's been a hell of a journey.
Wow. So the implications are pretty big when we think about bolus learning that's pretty much all of medical school and the traditional way we've done it seems to sort of fly in the face of what the research is showing.
Very much so. And there is more and more recognition that retention of learning is critical. I mean, a lot of that sort of block education, so you do a block in biochemistry, a block in anatomy, et cetera, is largely dictated because of the administrative ease to set up these programs with the various departments in the medical school. So you mobilize the biochemistry department for 6 weeks. Okay, anatomy, your turn. But actually, that appears to be detrimental to actually. And I was at Harvard Medical School during the new pathway, and they had a big issue with trying to eliminate tests because they didn't want a stressful, dog-eat-dog environment. But actually, the process by eliminating those tests, I think they dramatically reduced our ability to retain the material longer term. Did us a disservice, in effect.
Wow, interesting. You mentioned, too, that you were working on some, you were infusing some gaming theory to increase engagement?
Yes.
I'm curious about that.
Well, it actually came about in an interesting way. Again, they jerry-rigged the system for me at Harvard. And the programmer with whom I was working, Ron Rouse, decided at the end that he would put in a little panel that would show, again, these were multiple choice format questions where people would submit their answers, that he would put in a panel so that people could see how they performed relative to others. Right. And this turned out to be actually the most addictive element of the methodology, which we found actually, for the web-based teaching modules, you have to give root canals to get people to complete it. But here, actually, people enjoyed it. They liked the fact that it was bite-sized. They could see how they were doing. It presented them with a challenge. And then being able to see how they did relative to others was very engaging. So over time, we've included more and more. There are a whole range of these game mechanics. And just to clarify, we don't insert stupid games into the education. It's trying to take the mechanics and elegantly integrate them to see what's effective and what is not. Mm-hmm. So there's an appointment dynamic whereby those the questions, when they're sent out, expire and are counted wrong if you don't answer them in a time period. And that is incredibly motivating for people to kind of keep up with the program. And so it's almost like having to harvest your crops in Farmville before they die.
Interesting.
The other is that we have now structured it so that people can work through a series of questions, explanations over time. And so there's a progression dynamic as they master content and move on to additional content as well. And then we've also included leaderboards. And that's been fascinating. Again, all of this has kind of been an interesting development. With the first year ethics students at Harvard, this was right when Facebook had just taken off. We did a trial looking to see if we could use leaderboards among them answering questions on different clinical ethical scenarios. And we were sure, everybody's all over the web, Twitter, Facebook, they won't mind their names on it. And so what we did, though, is it was not very well accepted by the students. And we were scratching our heads. And then it turned out, and then made obvious sense in retrospect, is that they didn't want to be shamed in front of their peers by showing how well they did relative to others. That said, QStream focuses on Salesforce enablement, and the Salesforce teams, they live and die on kind of seeing their names on leaderboards and showing their performance relative to others. So their having the name on there culturally is very well accepted. But we found in the healthcare domain that actually it's not. So we've been doing a variety of different approaches. One has been to give aliases to people. So initially at the VA, we were using the methodology for patient safety training among the nurses. And their teams were their wards, and this was about 250 nurses. We gave them their aliases were band names of the 80s and 90s, and so they would be calling each other on the wards 9 Inch Nails and back and forth. So the aliases got out. We now use it with 2,300 of the VA staff for Joint Commission accreditation and healthcare quality, and I can't think of that many band names. So now we've moved on to an animal name with a funny adjective. And it's generally been very well accepted, except for the Marine who contacted me to complain that he didn't like his alias Pink Cobra. So it's been fun.
So
actually, can I touch base on one quick thing?
Sure.
It's been within medical education, there is very much a hierarchy of outcomes. And as I mentioned when we started here, the key here is not to look at bells and whistles, but actually get randomized controlled data in terms of what works and what does not. And the hierarchy in medical education are initially, is there learning and is it retained? The second is, can we actually change the practice patterns of clinicians? And then lastly, and most difficult, is can we actually improve the health outcomes and measures of their patients? So we have a lot of initial data showing that this methodology can improve the acquisition and retention of knowledge. We did a randomized trial with PSA screening here in the VA system, and we're able to show that those clinicians that were randomized to receive the intervention had a 40% durable improvement in their prostate cancer screening as compared to those who did not, out to over a year after the intervention.
Wow.
And interestingly, the U.S. Preventive Task Force guidelines came out during the middle of our follow-up period and had absolutely no demonstrable impact on the screening patterns in either the controls, the intervention, or both together. So it appears that that's really not an effective method by which to disseminate guidelines. But on the other hand, the space education methodology was.
So in other words, just declaring guidelines is an ineffective way of changing practices.
And it was actually an unexpected finding. In fact, this project we did for the prostate cancer screening was part of a research career development award I had. So we later realized that it probably wouldn't have gotten funded as a grant in of itself, because it turned out that when we tested people on their knowledge of the prostate cancer screening guidelines, they knew 70% of them. I mean, they really knew a great deal of them. That said, in spite of that high, starting point, we were able to show that 40% improvement. So our hypothesis, which we're still working to kind of elucidate, is that for some reason, presenting a challenge to someone in a question format, having them engage in a clinical scenario as to what they would do and receiving immediate feedback and reinforcing it appears to help very much with even though they might know the guidelines, putting it in this context actually helps them translate it into clinical practice.
Excellent.
So two other quick things. One is we just completed a trial that we, among 111 care providers in the Northeastern VA, randomized them either to receive a spaced education program on hypertension management or to receive the identical information in an online posting with some email reminders. And we followed their 14,000 plus patients with high blood pressure to see if the program would improve the time to normalization of their blood pressure. And we did. And now we're moving on in an AHRQ study trying to use this directly with patients focused on can we help them improve their control of their diabetes.
Wow, fantastic. Wow, so this is some broad-ranging research and some findings that affect not only the teaching, the practice of the doctors, and hopefully some outcomes down the road, right? Wow, fantastic. Yes. So I'm curious, as you look around on the web and on digital devices and things that you've seen developed for education. Are there some sort of standouts that you've seen in terms of programs online, resources that strike you as best practices? Not necessarily in medicine or surgical education, but
So,
what have you seen?
so interestingly, I met with the founder of Up to Date to see if he would think that this methodology would be helpful. I hope I'm not giving away state secrets by mentioning this, but to see if the space education methodology might be a mechanism by which Up to Date could effectively deliver their content to subscribers. I could imagine where someone would, I'm a urologist, sign up for a urology stream or however, and then get questions as how guidelines. Point that was made, which I thought was fascinating, is he said, it's really not in our interest to have people remember the content because we want them to keep coming back to the site to look it up because then they'll be updated with the newer information. So I might disagree with that approach to education, but I thought it was a very interesting comment.
That is
so in terms of viewing the educational things, in terms of what I have looked good, there really has not been much recently, except for one that came out just a couple months ago, which is the New England Journal's Knowledge Plus, NEJM Plus, which uses unfortunately for us surgeons, it's focused primarily on internal medicine, but it covers a range of topics. But it's a beautifully structured interface where it provides questions and feedback and reinforcement over time. It's headed by Dr. Graham McMahon, with whom I've collaborated on many projects. And so it involves many of the principles that we've used for the space education.
Wow. Okay. Good. Well, I think we got another bunch of topics to probably unpack for another day if you've got the time. But that's really some interesting research, and I really appreciate your input. Can I talk to you another day on some more stuff?
Would look forward to it. Thank you for letting me join you.
Great. Talk another day. Adios.
Thanks.
Thanks for checking out the Op Report. Help us keep conversations alive on topics in general surgery. Check out more episodes of the Op Report and other OnSurge content here at YouTube. Find us at Facebook. Follow us on Twitter. And find our homepage at onsurge.com. Join the conversation and tell us what topics you'd like to hear about and what people you'd like to hear from.